Okay. Hey, Tier 1. This is Dustin. Apologize for the late start. We've got a little bit of technical difficulties. So, today, one of the things I'm excited about is the fact that we have three awesome experts who dedicate their lives to helping people with mental health conditions and relational challenges and personal challenges. And part of the challenge we've had is getting Dr. Paul Keck access to our internal Teams events. So Mike Sandberg is currently working with him offline to get him access, but we might have to do some weird pivoting here at the end. But right now, I have Tom and Stephanie joining us. But before we get to the panel part of this, I'm gonna do what I've been doing is kind of like connect us back to the data, connect us back to the narrative of start the conversation, and get us in the space of mental illness. Remember, so we've been talking about these numbers. We kicked it off with this first number, 1 in 5. Remember, this is 1 in 5 of us at some time this year can or may be diagnosed with a mental health condition, and which is a huge number. And a lot of these folks go untreated for long periods of time. And so to put that in perspective, if you think about 1 in 5 of us, remember that we may not be that person, but all of us pretty much are affected by someone either here at Tier 1 as a friend or colleague, either personally or a family member. And so when we talk about this, it's not just for ourselves today in this moment, but it's this year, and it's also the people that are surrounding us and our ability to support them through this journey. So, and another thing is using our own words. Remember, we've been trying to put in perspective the language of what this sounds like. So when we put out our survey, we heard things like this. Seeing the way that mental health problems can multiply when they're passed down to family members but remain unacknowledged and unspoken, open my eyes to the power of communication. So we're hearing when we ask people the way they've seen mental health issues show up in their lives, you can start to see how the impact of it trickling down into family and how it even came up in our passion. So I'm guessing this person who loves communication saw firsthand the power of that. Another one is I spent many years ignoring, denying that something was off, mainly because I was embarrassed and felt like I wasn't crazy enough to seek medical help. And I think we've heard tons of comments actually through the panel conversations around, where's this line of like, when should I seek help and when I'm not as bad as this person over here. Well, when's that line? Another one here is it doesn't matter how you get there. Life triggers, family genetics, or neurochemical damage. You get to the same dark place and you need help getting out. The good news is that I got that help. Doctors, counseling, medicine can fully function and not be buried by it, and anyone can get that help. I love this is another informed comment here. We've already started to see the language of the triggers, the family genetics, and the chemical imbalances that happen that cause some of this and sustain some of it over the long term. And we're going to help get this team to unpack some of that for us. And the last one here is I have extreme anxiety issues off and on, and when it went on, it's debilitating and I can barely function. I have been treated in the past, but therapy and medication, but neither work very effectively. And again, we're not here to say what will work for people, but we definitely have experts here that can maybe like shed some light on why doesn't counseling or medication work all the time, because everybody's unique and our journeys are unique. So we've been using this metaphor of comparing mental illness to physical illnesses, and one of the aspects that I want to make sure we highlight this week is this genetics component. So like cancer. When we have mental illness in our family, we are more susceptible to have that in our own personal lives, and so that's why when we ask that question about family history, are you aware of your relative's mental health history? This is an important part of that equation where, as we consider our risk and how prone we are to these things, the more aware we are of our family, the more likely we are to be aware and notice things as they arise. So if you look at these numbers, almost 60% of us could probably use some more digging into our family history and how it's shown up in our lives. And I know personally, when I've had these conversations, I honestly have found it to be a very bonding conversation. It can be a very bonding conversation because you get to understand someone, and like on a personal level. I remember when I talked to my dad about it, he opened up for the first time that he had never heard the words "I love you" as a kid, and it was a big part of like how his experience as a child. So there's an opportunity here to not just make it about mental illness, but about like how they got to who they are. So one more little framing thing before we get to the panel, and I'm so excited about this. You know, we talked last week about this journey that we're all on, and in every moment, every experience, we bring with us our genetic predispositions and our past experiences that kind of shape the way we interact with those moments. Not knowing where the destination is, but trying to navigate life in the best way we can. But based on those past experiences, you know, our thoughts and feelings, these positive, negatives, and emotions, they can shape the way we interact with our moments, you know, in a very small way, in a very big way, and maybe even a sustained way. And the more we let those gremlins, those, you know, Mark calls them the gremlins are those negative thought patterns continue, the more they start to shape and distort our actions and our feelings and how we treat ourselves and each other. And that's when, instead of this wellness journey, we get more of this illness journey, and it sends us on a detour in life where that moment becomes a blockade, something that keeps us from being our best selves and sends us down a path that leads towards one of these mental illnesses. And, you know, the top three that we're going to focus on today are depression and anxiety, obsessive compulsive disorder, and addictions. And to help us unpack that, I've got hopefully three panelists here today. Stephanie Shell, no relation. I'm just kidding. She is my wife, and I'm so excited for you guys to meet her. She's a counselor representing the counselor field. We have Tom Lindquist, a good friend of Kara Gilmore's, a psychologist, and Dr. Paul Keck, a psychiatrist and CEO of the Linder Center. So I'm going to stop sharing my screen here and switch back over to the full video. So I've got. Why don't we go ahead and start with Stephanie? Can you, like, you know, you're here representing counseling, the field of counseling. Would you mind spending maybe a minute or two just kind of like giving us a sense of how you got here? What made you want to become a therapist, and what was your journey to get there?
Well, when I've started to reflect on that story, it's kind of funny to me because at the end of undergrad, I had 3 credit hours of an elective that I could take, and nothing was of interest to me. But Dustin was thinking of doing counseling, master's in counseling. And so I decided to enroll in a counseling course to better understand what his experience would be in that career path. Somehow I ended up actually choosing that for myself, and he stepped out of it. But it kind of gives me a chuckle that a big part of being a counselor is a desire and ability to connect with another person's experience. So I guess that's what drew me to counseling in the first place.
That's awesome. Tell me about the education. Like, what does it take to become a counselor? Like, what do you have to do? And like, what are the common kind of things people you treat and what you treat?
Yeah, so counselors have a master's of arts in counseling. Some will go on to do further education, but that's the requirement for a counselor. And then, of course, licensure. Most people who practice as counselors, depending on what they specialize in, they may treat children, teens, adults, like as individuals with mental illness. And then a lot of counselors go on to develop a specialty in couples or family counseling. So that's one of the things that I did. I went on to do training in emotionally focused therapy, which is a model that helps us understand relationships and attachment, and is primarily used for helping couples and families.
That's awesome. So you guys can see why Stephanie's my better half. She's been a big influence on me, and so, you know, you're representing the counseling field. But you are, so can you do me a favor and, you know, define counseling or counselor? Because we got a psychologist and a psychiatrist here. I'd love for you to how would you define what a counselor is?
Mm-hmm. Well, often there's some overlap, but for people who are licensed as counselors, we help people work through different mental health disorders and relational conflicts. So people often come to us when they're just feeling stuck, or they're just feeling like they can't get where they want to be, or life is kind of too much because of the symptoms that they're experiencing. Some people have a good sense that they know that they need to address anxiety, and sometimes it might be a little bit more elusive, but we help diagnose mental and emotional disorders, and then work together to define what the best treatment for that process would be. And we like to really focus on evidence-based treatments that are that will most likely be effective for that person, and then monitor how the progress goes along the way.
Awesome. I really appreciate you sharing all that stuff. Let's meet our next panelist, Tom. Tom, you're a good friend of Kara's. Would you kind of answer the same kind of thing? Like, what was your journey to get to be a psychologist, and what drew you to it, and what's it like for you now?
Sure, I'd be happy to do that. I have an interesting story too, and I think everyone kind of does, especially when they end going up into this profession. I studied art and psychology in undergrad, and then actually went for a master's in a combined counseling and art therapy program. So I'm a registered art therapist still, so I still incorporate art therapy,
Cool.
Expressive arts therapy. And I also worked as a licensed counselor for probably about 5 or 6 years. So I can definitely relate to all Stephanie had to say about counseling, all of that. So my journey was kind of through the arts, and then I decided to go back to school and pursue my doctorate so that I could work as a psychologist. And that's where I'm at today. I've been licensed for not too long now, but licensed in Pennsylvania this year.
Excellent. Yeah, Kara spoke really highly of you. Can you tell us a little bit more? I mean, it's cool how I can see like your personalities coming through, like the focus area and the passion that you bring, and like your own unique personalities. Can you help us better define the psychologist role, and maybe even compare it a little bit to how Stephanie defined the counselor role?
Yeah. No, I think that's a really good, important question, because there's oftentimes a lot of uncertainty, confusion about who's who and all of that in our field. And like she said, there's quite a bit of overlap. I think the things that define differences would largely be around like testing and assessment and evaluation. Psychologists often do a lot of that kind of thing. So testing would involve psychometrics and tests like things for ADHD, different types of personality things, screening. Certain professionals in certain occupations go through a psychological testing or a psychological assessment. So that's something that you'd see a psychologist for typically. Some stuff around research and organizational change and organizational management, consulting around that, something psychologists frequently will do. And then there's a whole bunch of psychologists that are more academic and research oriented. I primarily do individual therapy and group therapy, and I work in college mental health. So there's actually probably quite a bit of overlap between Stephanie and I on a day-to-day basis in terms of what we do, largely being psychotherapy.
Excellent. Thanks for sharing all that. This would be the time where I would pass it off to Dr. Keck if he were in here. So we're going to pivot a little bit, guys. Mike Sandberg is still working with him. We're still hopeful we can get him in here. But instead of going to Dr. Keck, I thought maybe why don't we go on to maybe digging into this first common mental illness, depression and anxiety. I would say my guess is, and I don't know, but a pie chart, a big portion of that pie chart in that 1 in 5 would be related to depression and anxiety. And so let's spend a little time on that as we're getting Dr. Keck in here. Steph, I know you serve a lot of clients and patients with this disorder. Let's just kind of build our vocabulary here. What are the most common signs and symptoms of anxiety and depression? And what might the journey look like for someone to get to you with those symptoms?
Mm-hmm. A lot of times people are coping with symptoms for quite a while before they reach out. They're kind of like exhausting their ability to function day to day. When it becomes too much, then they might start to reach out. With anxiety, we're usually looking at the presence of some of these symptoms for about 6 months. And so that kind of gives you a sense of how long most people, that would be a minimum often for someone before they reach out.
Yep.
But a lot of the things I'll start with anxiety and then kind of shift over into depression, but we see a lot of worry and nervousness, those kind of irrational fears where it's like you just can't shake it. You can't talk yourself out of it. One of the other common things with anxiety is a lot of somatic complaints. So a lot of gastrointestinal issues, sometimes even panic symptoms can even feel like numbness and tingling, or heart racing, heart palpitations, headaches, or hyperventilating. And so when people experience these things, I think often for a lot of people, they're initially concerned that they have some kind of physical condition. And it is good to get that kind of stuff ruled out with a doctor. But we like to help people understand that those things they're experiencing are real, even if they have this more like emotional kind of origin, or that's a piece of it. That's going to be how we'll help address it. But yeah, if a person is dealing with gastrointestinal issues, that symptom is very real. One of the other things that I see a lot with anxiety is irritability or agitation that pops up, especially with a teen population. But man, even with me, if I'm feeling anxious, I'm more irritable. Issues with like concentrating, trouble sleeping. And then another significant thing with anxiety is avoidance, that when things start to feel hard and scary and we're just on edge all the time, that our instinct sometimes is to back away from all of those things that feel like too much. And what really happens though is that reinforces the anxiety, and often that's when people start to deal with depression on top of anxiety. They don't always partner up, but they sure can partner up pretty well. So, you know, I find that especially once people are starting to avoid more and more parts of their lives, then we start to see some of the symptoms of depression that can sneak in. Things like feeling hopeless, feeling more irritable and more tired. Things are becoming more difficult. Sometimes like that sense of worthlessness can be there, just feeling drained and tired. A lot of sadness and heaviness that's there. And more difficulty concentrating. You know, with depression, things can also show up one side or the other. People can feel like their appetite and weight gain goes up or it goes down. So each person is different in how that will affect them. And then I think one of the other significant parts of depression is that losing interest in things that we usually enjoy or take pleasure in. And so life just, that kind of instinct to just kind of shrink away starts to happen. And that reinforces it, because then we've got all these things that could help kind of lift us out of some of those dark places. And once we stop doing those things or stop using those resources, we are more likely to become entrenched in those problems. And it feels like that's all life is often for people. And it's worth noting that with depression, suicidal ideation is very common. And that can range from being a fleeting idea that just kind of comes into the mind and then leaves, or it can start to become a more pressing or persistent thing, where someone becomes much more willing to ruminate about that and consider that as an option to get relief or freedom from those really difficult experiences that are happening inside.
Wow, that is complex, by the way. There's a lot to unpack there. You know, especially, you know, TiER1, last week we talked about how there's a lot of just the nature of our work is like high pressure, you know, either an intense meeting with a lot of stakes, or like a deadline that you're trying to driving to. You know, before we get into treatment, we've had several questions around what people are calling like the tipping point. Tom, do you mind if I pass this one to you? So in that journey of all those symptoms, you know, and you said something around 6 months, like if we're experiencing them for 6 months, how would you talk about the tipping point? When do things go from like kind of not right to looking for help? Like what advice or recommendation would you have for people in that journey, kind of navigating, hey, I'm just like nervous because I got this thing coming up, versus like I have a real problem here?
Yeah, well, certainly the duration comes into play talking about diagnosis, just because we do have to differentiate between everyday stress and anxiety. We all have anxiety at some level, and ordinary sadness and periods where we're down. In terms of the tipping point and seeking help, I would say, if at all possible, never to wait to the tipping point. A lot of research supports getting help earlier will actually help the treatment progress faster and help you get well faster. And that's particularly true for depression. If you're able to get in to see somebody earlier and start to make a lot of changes, there's a lot you can do in terms. Most therapists will probably work around a holistic perspective, so looking at your whole lifestyle and what can be different. So the earlier you can get in for any of those things can be really helpful. Sometimes I'll see people that come back who have had depression before and they can reoccur. So they're coming in much sooner this time because they understand that like it's starting to occur.
Yeah.
It is a tricky thing though, because it's not exactly always supported that you seek help for these things, and a lot of it mentality can be kind of pull yourself up by your bootstraps and get through it.
Yep. But
when you start to notice that it's impacting your day-to-day life, beyond just that week or that day, it's not just a bad day. Especially, I think, as it becomes closer to a tipping point, it will become more apparent probably to those around you. Anybody suggesting that you might want to seek help is also a good thing to pay attention to. So any sort of those warning signs that things don't feel quite right, because it really, no one's going to be, I cannot imagine seeking help from any sort of counselor or psychologist and not being certain about what's going on, but that's completely fine. And even if it's just a one-time thing to consult to see, where you might fall or what kind of things you might get some help with, I'm sure that all of us would be more than happy to talk to you more about that. And sometimes you can even just reach out to some clinicians for like a phone consultation before even making more of a commitment to coming in for a session. So
and that's an okay thing, picking up the phone and calling your local counseling center and not unpaid kind of like help navigating.
There's a lot of different options for how you could seek help that way, whether it's like a clinic or counseling center. There's a lot of private practices out there. There's a lot of independent practitioners. I have a small private practice that I would be happy to take a phone call from somebody. You're going to get a whole lot of different responses. My hope is that everyone would be very accommodating and be able to consult with you and talk for a little while. It's something that I practice just because I feel like it's ethical and also just something that I do because I believe in being helpful in that way.
Yep.
But if not over the phone or consulting, you could make an initial appointment, and that would be an opportunity to talk much more about all your concerns and figuring out what's best for you. Making a first appointment is something also we could talk about at some point, but I think that most therapists that work as I work understand that it's important to find a good fit too with people. So if you do call, it doesn't have to be that you're committing your life to this person or that
right.
You sign the paperwork and you are locked in. I think a good clinician will be talking about how good a fit you are together. Yep. And if it's even makes sense to keep going or how often or what that might look like. But reaching out and getting support just initially in whatever form that is, most clinicians, I think, in my heart, I believe, will want to be helpful in getting you to the next step, the next resource.
Awesome.
That might be.
Excellent. Thanks, Tom. So let's go back to our journey. So we kind of having these signs and symptoms, and we decide at some point to reach out, and we make that phone call. Steph, let's go back to you. To what's the treatment look like? What's a typical treatment for anxiety or depression?
Well, I think the first part of what you want to do is it's assessment. It's you've evaluated those symptoms and you've gathered more information to determine what's going on and what will be helpful. And there are a lot of really effective treatments. So you kind of, ideally, you get to work together with your therapist to discuss what some of those treatment options might look like, and then to decide to move forward. One of the things that we've started to do in our practice is kind of define these steps for clear direction, where we define what the problem is together, and that we work to bring the client in on the conceptualization of understanding how they got there. And then we choose treatment targets. So that's basically really being clear about what do we want to focus on during therapy that will be helpful, and we'll play a role in that. So, you know, for some people that might be like being able to build skills or knowledge, or even just like tracking their own experience so they can understand the way anxiety or depression is playing out in their lives. And so that might be using CBT, it might be using more of an acceptance and commitment-based model. But that usually means that there's some kind of like understanding that a person develops in therapy and that gets worked on and processed in there, and that they're taking something outside and doing work outside of that as well. That's usually when people get the best results, is when they're committed to the process and they're kind of finding ways to grow or make sense of, or even just like kind of catch themselves not doing anything about it and noticing what that happens, and being able to come back together and work through that. So it's good to have a plan for what that looks like. And then we also really like to make sure that we're defining, like, what are the markers that'll help us to know that this is working? Those are good questions to be able to ask yourself. Like, what do I want to see change? What could be different that would help me to know that therapy is playing an effective role in this process? Because, you know, like one of those comments that said that medication and therapy wasn't very effective, that might have been that there needed to be some pivoting to some different therapies or treatment models, or get a closer eye on that medication or pivot medication. So when it's not working, it's so important that you talk about it, because, you know, ideally your therapist wants to hear about that and then wants to understand that better, what's not working, so that we can work with you to pivot. Because sometimes that just means we can like dig in together and understand some of the nuances that are getting in the way of like buying into the process, or what you're doing in and outside of the session. If you're feeling uncomfortable with the therapist, like you can't be real or disclose everything that needs to be disclosed. So just checking in about that kind of stuff can be helpful. Or sometimes, like, if you just feel like I don't even get what this is or how this is helping me, or I don't like it, then that's important information. And it's totally appropriate information, because then you can work together to figure out the plan.
I was going to say, it sounds so different than how like TV even stereotypically show the counseling experience. You know, like, you know, there's like the Mad Men version where they're like sitting, you know, laying back in the couch and they're not even making eye contact with their therapist or their counselor or their psychologist, to even more recent versions where like the counselor is like challenging them in these really provocative ways and like clearly isn't trying to build a bond or relationship with the other person in the room. I'm curious what your guys' reactions to those kind of stereotypical kind of Hollywoodizations of the experience. Tom, let's hear yours. Yeah, I'm curious. I see you laughing, buddy.
Yeah, no, I was trying to think of, I think it's the show In Treatment. I forget what that's on, but that, I think, I've heard that does a decent job. But there are a lot of stereotypes out there. You had the kind of the whole spectrum there with like a very psychoanalytic approach, which is much less common today. So I'm not sure what the other approach would be, but much more confrontational, which, you know, at times you have to do a little bit like that. But so I guess in terms of the question, it would be just all the stereotypes, what is it really like? Or is that kind of what you were thinking?
Yeah, well, it just seems like there's more of a relationship than I think people expect.
Right. So I definitely, you know, when I explain my approach, I usually start with the word relationship, actually. So I think that really defines what therapy is all about. So what most therapists offer is like a professional relationship, but a relationship, and all the research supports that as being really the biggest factor for being what helps change to occur, is that you have that supportive relationship to help support that person in making these changes in their life, whether they're small things or bigger things, and exploring and understanding themselves better. So so it is much more of a relationship, and I appreciate the idea of talking to your therapist about what's working and not working. I often bring that up myself. And a lot of times, when you're meeting with a therapist, sometimes you're talking about, you're talking in a way that's talking about what you're talking about, which is kind of putting it, but you kind of process things at a different level. And that's something that, we encourage, and usually becomes part of the therapy then, is talking about, well, how is it going between us? Like, is this, helpful? What's not helpful? That kind of thing.
Yeah, we haven't had a chance to dig in on the medication side. You brought it up, Steph, as a part of like what's working, not working. And this is where I really wish we had Dr. Keck here to help us process that, because the key difference in a psychiatrist versus a psychologist and a counselor is that they can prescribe medication as a part of this process. Can you guys maybe speak to that a little bit? Like how does medication play a role in anxiety and depression? And then I'd love for us to switch gears to OCD so we can kind of cover a couple more diagnoses.
Sure. I think each person walks in at a different place. Some people might have already started by seeing a prescriber for medication. And then sometimes people are a lot more nervous about that idea, and they want to get started in therapy before they would even consider medication. A couple of the things I might point out is just that sometimes when people see a general physician for their psychotropic medications, that some important things might be overlooked, and so there's real value in seeing someone who specializes in psychotropic medications. Some of the stories that I've kind of heard from psychiatrists and had the experience with my clients is that sometimes general physicians will be very cautious with the amount they prescribe. And I've heard a lot of psychiatrists say they didn't get anywhere near the effective dosage. And so then sometimes people can get really discouraged because they'll pivot from all these different medications and none of them seem to work, but they also didn't really get to the effective dosage. So they didn't have a chance to test it out. So I have had people then switch to a psychiatrist, then get up to the effective dosage and then see a difference where it was working. So, different people go through different parts of the experience, but that's one of the things that has happened several times. So I don't know if Tom has had different experiences like that too.
Yeah.
Go ahead.
Okay. Yeah, no, I'm glad you brought that up, because I think a lot of people do end up getting an SSRI for depression or something for anxiety from a general physician in a well-intentioned way, but that I've definitely seen that it can be too low, which makes sense because they're probably being cautious because they're concerned about what could happen, like if they're bipolar and they could get set off like a manic episode or something. But at the same time, seeing a psychiatrist is ideal, absolutely ideal, and I think it can also be helpful if you are going to see a physician that you find a therapist as fast as possible, because oftentimes the therapist will be able to help you navigate the medication stuff a little bit. We're not going to be giving you medical advice, and we're not going to be prescribing medication, but we do learn a lot about it. We would be able to tell you like a red flag, like that should probably be what you're taking, or we're not sure about that, we should ask your doctor about that, and then you can follow up with your doctor. But yeah, I definitely think Stephanie was saying about seeing a psychiatrist is absolutely the best thing you could be doing. And again, like combined therapy and medication is what research supports is most effective. It also depends on the severity of the presenting concern. So much more severe depression, you really do need it. You almost need to have medication, I think, at least in the beginning.
Yeah.
Severe anxiety, OCD, which I can talk more about in a bit. If it's more severe, especially, you really definitely probably need medication in order to make progress in therapy.
Awesome. It makes sense, especially when you talked about a lot of the signs and symptoms. It might start with tummy troubles, and then when you go to your general physician for these, physical symptoms, and they might prescribe you something for that, just general medication. I've actually heard of that story a few times, but not partner with therapy. You can imagine how medication can get a bad rap in this process. So before I switch gears to OCD, there were several questions from the group about basically getting someone you love to get help. We're looking for play-by-plays here, because people are like, give me some language, give me some love. So if my if someone I love is unwilling to get help, and they need help, what do you recommend?
They're
unwilling. That was the language. That was the language of the question here.
Yeah. Well, I think what's difficult is that there are things that are within our control and there are things that are outside of our control. And so while you can't make a loved one go to therapy, unless it's your child, and even then it's best to kind of come together in that process when you can. But what I would say is just that being able to reflect back what you're observing and experiencing with that person can be a really helpful way for them to take note and start to maybe buy in or just accept the idea that things aren't okay. Instead of forcing people's hand, it's that alignment with them. And so, sometimes it can be hard to hear from someone like, you've been really grouchy lately, you've been really hard to be around, or you don't seem like yourself. That's hard to hear from a person. But when we can say that in moments where we're not blowing up at each other, sometimes we can just start to take that feedback in little by little. And the other thing I would just say is that, like, curious questions are really powerful. So to be able to say, what do you think is going on? Or what do you feel like you might be ready to do about this? Instead of telling them what you think they have to do or they should do, can you help them kind of get curious and nudge them along in that process? But if you push too hard, sometimes it's just we lose it. We lose that connection because when people don't want to be pushed, they just kind of back away. So if you're really feeling like nothing that person is not open to it, there's these concepts from motivational interviewing that help us, and it's a real focus on empathy. And I just think one of the concepts is rolling with resistance. So when people are resistant, sometimes I just move back into that empathy posture. This is really hard. You just don't want to even do anything about it right now. And I know that's simple stuff, but it's really powerful. It's a lot of what we do in therapy to help people move towards a place where they're ready to do something and make some changes. So
I could imagine a bunch of TiER1ers with their pens and paper, motivational interviewing. Tom, I saw you getting super excited about something there. Was there something you wanted to share?
I was just agreeing with Stephanie. It's actually hard to add anything to what she said. She's really sharp, and that's a great answer. I was going to say similar things around just being there to be supportive. And there is a point, obviously, when you need to intervene if it's something that's like life or death or more serious. But largely, it does need to be that person's choice. And if it is at some level their choice, it's more likely that the help they get is going to be more effective too.
Yes.
Awesome.
So I think that being empathic, being curious, and all those things are really great.
So I got a question in here, real time here. Steph, you mentioned CBT as a part of your treatment conversation.
Mm-hmm.
There was a question here about like is DBT a good choice for teens suffering from social anxiety and depression versus maybe individual CBT, cognitive behavioral therapy?
Well, a lot of times DBT gets used as a treatment model when teens or adults are experiencing really big, intense emotions and they're having a hard time tolerating distress. Mm-hmm. So there's a lot of ways DBT can be used, but one example would be like a teen who's self-harming, self-injuring, because when we can develop the capacity to tolerate distress, we can kind of weather some of the difficulties of emotions. I don't know that I could answer that question specifically, but a lot of times was it social anxiety in the question? Yep,
social anxiety.
A lot of
possible depression.
Okay. A lot of times with social anxiety, some cognitive behavioral theories, like interventions, can be helpful because it can help a person to understand more about their experience, thoughts, feelings, and behaviors. But I'd say a really powerful component of treating social anxiety would be where you're facing fears, you're actually developing the tools you need to step into dealing with things that you want to avoid. And if treatment for anxiety is not utilizing that exposure element of facing fears and starting to address those things, it's not going to be as effective as it needs to be. Sometimes we really have to work with people to be ready for that and to equip them for it. But we don't want to reinforce the fears by helping them hide away from everything. Those social anxieties aren't going anywhere. They're just going to carry with us into adulthood.
Gotcha. Awesome. Thank you for that. So let's switch gears. We spent the majority of time on anxiety, depression. They cover a lot of bases with our questions, so I think it was worth it. I'd love to kind of try and get in OCD and addiction with the last 15 minutes we have here. And I'm kind of weaving in questions that I'm getting from people as we go through this process. Tom, can you, let's start with this, similar to anxiety and depression. Let's start with the signs and symptoms and the journey to get to your office.
Okay, yeah, the journey to get in. Specific to OCD.
And what is OCD again? Like, let's unpack it all the way.
Sure, to unpack it a little bit. Well, just broadly speaking, it affects about 2% of the population at any point in adulthood. It most commonly begins to emerge around the ages of 8 to 12, but there's another period a little bit later, like late adolescence, early adulthood, where it can also start to emerge more so. And it can be a little bit higher in like college student age or a little bit older. That's generally the highest population. But basically, if you break it down, you have obsessions and compulsions. So in terms of obsessions, these can be thoughts most commonly, but they can also be images, they can be impulses, pretty much anything that occurs again and again. So it might be an intrusive thought that's causing a lot of distress for the person. It could be an image. Sometimes people imagine doing something to someone else. A really common obsession involves fear of losing control, behaving in like a really strange way, hurting somebody, or harming somebody else. And the person experiences these intrusive thoughts as out of their control, so they can't control the intrusion of the thoughts and the images, the impulses, such as hurting somebody. And then it's almost always experienced as distressing. And that is one thing that differentiates OCD from OCPD, which is a personality disorder. That usually the person doesn't have a lot of awareness for, and it's much more about personality style and traits around rigidity and that type of thing. But so for OCD, obsessions is the first piece, and that's the part that really causes the distress for the person. High levels of anxiety, lots of behaviors that start to occur in order to try to help them cope with that anxiety and the distress, or essentially what they're trying to do is lessen all the intrusive thoughts or all the disturbing images that are happening. So that's when you get the compulsions, which is sort of the second part to it. And these are repetitive behaviors, but they can also be thoughts. Thought compulsions are not uncommon. So this is used to sort of like neutralize or slow down the anxiety. Most of the time, the people that I've worked with are well aware that it's only a temporary solution, but it's the best way that they can try to manage the intensity of the obsessions. The difficulty is that it is temporary, and the more you engage in the compulsions, the more that you negatively reinforce all the obsessions. And negative reinforcement is basically you're taking away the distress, and then that reinforces again back to the intrusive thoughts. So it becomes a cycle where you're getting some relief, but you're ultimately actually making it worse by continuing to engage in all these different behaviors. And that's not to criticize someone about that, and be careful with that, but it's just the pattern that develops around OCD. So just to review really quickly, you basically have intrusive obsessive thoughts. Again, that could be images and things like that that are causing you distress. And a big, like in terms of seeking help, it is good to think about a lot of these things on a continuum, because people joke about having like OCD all the time, and it's very OCD of me.
Mm-hmm.
And that can be personality, but that can also be like some people can have subclinical levels of OCD, or some aspects of OCD that come up in their life, especially under more stress and things like that, as they try to control things. So I would look for the amount that is impacting daily functioning. So if you're starting to do things that are sort of compulsive to try to reduce your distress, and you're spending more and more time doing that, if it's causing you to miss other activities or avoid things, impacting your relationships, all those kind of things, which are some of the things you might look for any mental health disorder. That would be a great time to seek some help around that.
It feels like a very internal journey for the most part, like something that probably, I'm guessing, it's a pretty shameful journey, and or can be a pretty shameful journey. A lot of what you describe sounds like it's happening on the inside, and there may be some things coming on the outside, but and then at some point more and more. But I'm curious, like, how long does it take for someone to start showing those external signs, and how long before they start to see you?
Yeah. Well, I think in terms of what's observable, all the compulsions. I think that a really common one is hand washing. You hear about that one, more popular.
Well, what a time to be OCD about that.
Yeah. So obviously there's problems with that now because everyone's hand washing. But those types of compulsive behaviors, checking is something that's really common. So repeatedly having to check things, going back and forth into your garage or into your house, double checking locks. So those types of things might start to become apparent to loved ones or other people in your life. And I can see how there's a lot of shame around it, a lot of embarrassment around it. But when building empathy around this is connecting with that sense that you absolutely must go check again, or else it's going to be so distressing that you probably can't even concentrate and move on with your day. So on the one hand, if we don't want that to continue, part of getting help is to be able to reduce the need to do that. But at the same time, it's really understandable that that person's having such intrusive thoughts and obsessions about it that they need to do something in the moment, and that's how it kind of manifests. So I think you would mostly see different behaviors like that, or avoidance of things.
Right. So what's treatment look like for OCD?
So we were talking a little bit about cognitive behavioral therapy, or CBT. That would be the treatment of choice. There's a particular kind, exposure with response prevention, or ERP. That would be like the most research-supported intervention. And I can explain a little bit about what that is.
So I'm picturing like a room full of locks, if they deal with like locking doors, and they have to like resist the urge to not lock all the doors.
On some level,
I'm sorry, I shouldn't make jokes, but
no, and what you're talking about too, in certain instances, there's what we call like a specific phobia, and that sometimes has to do with like spiders, for example. And so for that actually is exposure with response prevention. The thing with the locks, that would probably be like the very extreme level of it. But with exposure and response prevention, what we're trying to do is obviously expose the person to the thought, the image, all that type of stuff. If it's a phobia, like you were describing, then it would actually be like the locks. But in this case, it might be around, not having, like, if they're worried about their house being locked, you would work towards not having them go back and check the lock. If it's 10 times, you might work on only doing it 5 times, and that kind of thing. So a really key part of this is to understand what that person is going to be able to tolerate, because you're asking them to go through a really distressing situation, and their distress is going to get worse before it gets better. But that's really the only way through it. So what you do with exposure is you create a hierarchy, and this is actually something that's really helpful with social anxiety. Is I'll actually make this with clients. 1 to 10 is a common thing to do. Write down like what the least distressing and most doable thing that you can face. So with checking locks, maybe not checking the lock when you leave the home would be like a 10 for them. So maybe you would have to start with something a little easier. maybe checking it once, maybe they come home during the day to check their house. So maybe eliminating that at some point. But you want to start with something that's going to be where they're going to have success and not just experience more distress over it, and start to feel like they can't do it, because then it's just going to perpetuate it more and more. So
Gotcha.
the exposure part is that, and then in terms of the response prevention, what you're trying to do essentially is get them to not engage with the compulsive behaviors as much. So for example, I guess staying with our example, another thing I'm kind of skipping over, which I don't want to do, is in doing that and getting them prepared for exposing themselves to these situations without responding in the way they typically do. What you do a lot of in therapy is work around stuff like grounding techniques and breathing exercises, anything to help calm them down. You might even do visualization and go through what it might be like to walk away from your house knowing you're not going to turn back, what comes up, and then you work through that. And you help prepare them for the anxiety that's going to come. And you give them lots of tools and skills around that, grounding being one of them. And then you just gradually work on moving up the hierarchy, exposing the person more and more to the thing that's concerning. And it varies a lot depending on what that might be. And in terms of CBT, you might even challenge some of the thoughts they're having. So like how likely it is that your house is going to be broken into. This can also be a slippery slope, so you want to be careful because it is possible.
Right.
But you might look at certain things around the actual likelihood of certain fears happening, and that kind of thing. And then you can work on, some people work on replacing or challenging thoughts. I tend to work more on adding new thoughts to those, but that can be helpful. But I think if the listeners out there are looking for help for OCD, they would definitely want a therapist that's familiar with cognitive behavioral therapy, with exposure and response prevention, and those types of things. And that would be a really good place to start. And also just to add, the medication part again is usually pretty helpful for OCD. Most of the time that I've experienced, almost all of my experiences, I've had to recommend people seek medication if they aren't already on it, at least in order to get started. Because if you think about the whole treatment process itself, it might increase the distress anyways. So the medication can help them engage better in the treatment usually. So very commonly it would be both therapy and medication. Very
cool. Yeah, I'm glad you brought up the medication piece. This is again where I would have Dr. Keck kind of fill in some of the gaps. The thing I'm picking up on here though is this you guys are sitting in a room on a regular basis with these folks kind of on the longer journey, and a psychiatrist is doing these checkpoints from a medication perspective. So they're not the ones sitting with you long term working through this stuff. Is that right? Good stuff.
Yeah, most typically the psychiatrist, they have certain dates where they're checking back in to make sure that the dosage is good and just noting any other fluctuations or symptoms. And then there's a therapist that's working, either a psychologist or a counselor who's working with that person on kind of the nitty-gritty of that journey. I think I've heard a few examples of psychiatrists doing more kind of extending outside of that range, but that's been more rare. One other thing I wanted to note is that one of the compulsions that's sneaky and that a lot of people don't necessarily recognize as OCD is reassurance seeking. But when a person has a hard time trusting their judgment and they keep asking, kind of enlisting the people around them to I didn't hit anything, right? Did you look at it? Do you see it? You promise I didn't hit anything? Something like that, where they just keep going back over and over that can be a form of compulsion that's not as popularized.
Awesome. Well, guys, we're about 4 minutes out from our end time, and I can't tell you how grateful I am for both of you guys taking the time to do this, and for Dr. Keck and Mike Sandberg. I think they only gave up like 5 minutes ago trying to get into this. So if you can imagine how frustrating that would have been, and we'll work through those kinks for next week. So make sure we get our outside people in here. But I just am so grateful for you two and your time and energy sharing your expertise. Before I send you off, what question or what did we not talk about today that you would just really want TiER1 Nation to hear as it relates to mental health, their own personal mental health or someone else's? Wild card. Didn't give you that question, did I?
Well,
go ahead, Tom.
I was going to say, we didn't get a chance to cover addictions, and I guess one thing that I would want to leave too is that it's really helpful to take a broad look at like your relationship with all kinds of things in your life, whether or not you see that as a quote-unquote addiction or not, whether that's a substance or not. There's lots of things that we get addicted to. So I would encourage people, whether or not they would fall under having an addictive disorder or concern, just to look at the relationship they have with different things in their lives and how much control it has over them, and to reflect on that a little bit and see, whether that's alcohol or not, or something different. See, there might be a whole lot of freedom behind that if you can take a look at how much control you're losing to things that influence you. So that would be a message I would leave to people.
I love that, and I'm glad you brought it back to addictions, because it was a big part of what we were going to talk about today. But I appreciate you guys pivoting and kind of bringing it back to that. Thanks, man. And Steph, did you have something?
I would just say that relationships are a really important part of the context in which we exist. We form our sense of self based on our connections with others and our beliefs about other people as well. And so I guess just to note like that your relationships are really important. They're worth working on and attending to. And yeah, I just lost my train of thought.
Well, you're pretty dang good at them, and if I can speak for myself here, and I know you have a relationship focus in the way that you treat people. It sounds like you do too, Tom. The two questions I've always taken away from our conversations about attachment is like, do I matter, and are you there for me? And I really do hold on to those two questions all the time, because I remember when I was halfway through my counseling degree that I never finished, I remember thinking, why can't everyone have this education?
I wish.
Like, what would happen to the world of therapy and counseling if everyone got equipped with those two questions earlier in their lives? And we changed the system, not just like treat the issue. I'm really grateful for you guys. I'm going to leave everybody. I'm going to share my screen for just a second, kind of calling us ahead to next week. We're on mental illness, and next week we're digging into support. As a part of this process, as we get into support, we had two kind of like challenges for you guys in assessing your risk. One was a family history, just a way to get you to start thinking about and jotting down some ideas as you have connections and have conversations with people in your family to see how much you know or don't know about the history. And the other one was we pointed you to some NAMI screening tests to give you a way to start to self-assess and maybe gain some awareness of what the signs and symptoms are. And for those who need help, because we're getting in that space where maybe we're 3 weeks in, maybe you're starting to feel the need to seek help and question some things. We've got a whole section next week dedicated to unpacking what TiER1 has to offer in terms of help. Obviously, talk to somebody that cares about you, but if you don't know how TiER1 can help, next week we'll get into that. And if you are in need of like serious help, again, talk to somebody who loves you, but there's also some like crisis lines and some helplines that you can call as well. So TiER1, I appreciate everything you do for to help each other feel like they belong and they matter. And I'll see you next week with some of our insurance agents, Becky Foster, Greg Harmeyer, and Karen Nelson, to be talking about all the different ways that we can support each other and how TiER1 supports you. Tune back in. See you guys.